Well, like Georgia said, I'm with the Swedish Red Cross, the healthcare department, and in Malmö, we're one of out of 6 treatment centers that the Swedish Red Cross hosts in Sweden. There's one in Stockholm, and they started first, 1985. But like STARS in Malmö, we've been active for just over 30 years, I think. We're financed by the Swedish Red Cross itself, but also by state, region, and city councils. And we also have grants from external parts, including the UN, the Voluntary Fund for Victims of Torture. We're treating in Malmö just under 500 patients a year, and that does not include their next of kin, which we also have interventions for, which Jorge mentioned. Nationally, I think we're treating about 2,000 patients annually in these 6 centers. And in my team, which include all the professions that Jorge mentioned, we are 27 at the moment, so we're also the largest center. And in Sweden, Malmö is known, I think, for its multicultural setting, and we've received a lot of refugees for the past decades, I say, and it's very much a part of our city's identity, its profile, and how we address, how we are addressed and are addressing issues in Sweden. We're kind of like the Chicago of Sweden. That's what we're described as. But it's also a very dynamic and a lovely city to visit. I recommend it warmly. Our target population are refugees that we treat for the main criteria, PTSD and the trauma related to war, torture, or just flight, which we've included as a criteria just over the last, I think, 7 or 8 years. And as all of you probably are just as aware of as I am, these 3 often coexist. And it's also part of the, at least in the EU, our border policies have created horrific conditions under which people flee these days. We treat undocumented migrants and all the way up to citizenship, so to speak. So regardless of legal status, you can have support and treatment with us. I promised Nuria to cover the European perspective somehow. And Sarah, one of my colleagues who I think is also participating, has helped me with this perspective through the IRCT, which we're a proud member of. And I know that the centers in Europe at large are facing the same issues as we are, but addressing them pretty much the same way with some differences. The European Asylum Support Office have addressed these issues from a European perspective, and I think they're hosting a workshop these days about this specific European dilemma, where the COVID-19 has introduced new travel restrictions and national health measures in all countries that has caused a dramatic cut in asylum applications. In Sweden, we changed our laws 2015 and 2016 due to the heavy inflow of migrants to Sweden at that time. So we had already reduced very dramatically the number of refugees applying for asylum in Sweden, but this has caused a further cut. And the ESO, that is the European Asylum Support Office, are trying to predict future migration flows, but we don't know as of yet, as you all know also. And if the virus is to take hold in countries of origin and transit, it could potentially create a new inflow to the European Union, of course. When I introduced this, or when I created this presentation, we were not aware of a vaccine possibly having been discovered just the last couple of days, and let's put our hopes to that indeed. We don't know how the EU is preparing itself, but it has been preparing, is my perspective and opinion, for just the last couple of years to restrict the migrant flows anyway, but is now considering to do it, or how to be best prepared for the change that this COVID-19 might produce. There has, on a European level, been a challenge, of course, to all the civil actors, the civil society organizations of which we are part, due to the COVID-19 to keep functioning due to the restrictions, of course, in order to limit contagion, but also due to the economy, the financial situation, the border policies, which challenges us all. Sweden is presented in the New York Times, for example, as a cautionary tale. I think you're all aware that we stand out as an example of a different approach somehow to prevent contagion regarding restrictions. We have at large, if you speak in general terms, been less prohibiting, less restrictive on a national level, and also when it comes to border policies. So compared to other centers, I know that the IRCT centers in Europe have all been, I don't know how to express this, have been affected somewhat more, I think, where we've had less of prohibitions to relate to than in other European settings, where they've closed their borders. There has been a lot of restrictions within cities and so forth, which we have not had. So we're differing in that way. We too have changed into digital formats in very many ways, but I know that other European centers have been forced, or that it has been necessary for them to do at a larger scale, and it's been hard for some of them to actually attain that same level of care that they had before. As with us, it's the same. Also, that the Red Cross Center is differing from the rest of the Swedish environment in that we've decided to stay on so that we have all the staff here unless you show symptoms, and that is symptoms not of COVID-19, you know, it's just any symptoms. You have to stay at home in quarantine. But if you're not, we have decided not to work from home on a general basis. If you're healthy, you're here. If you have any symptoms, you're not. But what we share with the rest of the European centers and the European actors are, of course, the serious health consequences, where we too have many patients in risk groups, and also among staff, of course. There is also the already present, but the upcoming challenges when it comes to economy, when it comes to employment, and the migration and asylum issues within the EU. And this affects our population, our patient population already, where many have lost their employment, for example. Many have lost people to bad health, or even have fatal consequences and so forth. And they're also very much worried about their asylum situation, where there have been delays in expelling people, there has been delays in the handling of their asylum applications and so forth. Indeed, we too are affected by the efforts to contain and limit the further spread of the virus, and that how the consequences that this has had on our reception system. So I'm moving on to our own center, which I've tried to depict as a development along 4 tracks. The Swedish Red Cross, as the Red Cross and the Red Crescent organizations at large, have a special mandate, I'd say, in a human rights setting. So immediately on the onset of COVID-19 in Sweden, the Swedish Red Cross had several missions from the government in order to support society, especially targeted groups and so forth. And our treatment center has been part of this as well. So apart from supporting our own patient group, we've also helped by using members of our staff to start a helpline that the Swedish Red Cross has had for people who, apart from direct health and virus questions, have been worried, have been bothered by new restrictions and so forth. So there's been a national helpline And at first, our staff was part of that, but then we've also worked as supervisors for the volunteers who later on in the process has been the ones answering the phone. We've also been in charge of guides from the Swedish Red Cross who have been put outside hospitals, for example, to help and assist people seeking care in that setting. There's also several other things that the Swedish Red Cross has had the government have us help them with, but that has not affected our center. We have not been part of those efforts, for example, helping people in risk groups go shopping and so forth. But the Red Cross has been part of that, the Swedish Red Cross. The second track, and this is also kind of a temporal development over time, has been quite simply being a source of information and of correct information to our patients, to keep them informed, to keep them less worried, to give them support in all of those questions arising, because Sweden, as other countries, were kind of late when it came to several groups, and especially vulnerable groups, to get out there and get the correct information in place. So we worked as a source of information for our patients who have also been worried to a larger extent, I think, than the population at large due to experiences from before, and also being excluded by language, of course. So part of our efforts have also been translating materials into relevant languages. So our staff has had to educate themselves on COVID-19 and different measures that you can take in order to protect yourself. And also our office, in order to keep patients and staff safe, has changed a lot of rooms. There are arrows, there are signs, and all in all the relevant languages. The third track, of course, to keep and provide a safe environment for patients and staff has been to change treatment into digital formats. This might be the main track or the biggest change, I don't know, but we too, as many of you, have provided treatment from different settings, because some of our clinicians have worked from home when having symptoms or being in a risk group and so forth. The patients have received treatment from their homes due to symptoms or due to just being afraid to come to our center. And we've also had interpreters delivering their interpretations from home, from here. We've had all these different kind of settings, different formats, and we've used Zoom initially, but it turned out not to be safe. So now we are mainly, I'd say, using Teams, and there's also a private healthcare actor in Sweden who have actually for free provided a special app in which we've been able to deliver psychotherapy, medical consultation, social support, and with some difficulty, actually also physiotherapeutical interventions. It's been a remarkably swift shift. It might be me being outdated or too old, but I was actually amazed at how fast we were able to do this. And it's been very, very wise in order to maintain and facilitate contact with our patients. We've had seemingly good results, but we also have to and have had to keep considering the confidence, the secrecy, sekretess it's called in Sweden, you know, the patient confidentiality. Of course, keeping trust. A lot of our patients are worried about different formats that are not face-to-face. We've considered the activations versus isolation, that we actually facilitated them staying at home, which is something of a problem in other times. It's harder to keep a holistic and team-oriented approach when you're all on Zoom or Teams or whatever. There are new routines that have to be considered and that has to be solved in terms of confidentiality, but also in terms of assessments, suicide risk assessments, and so forth. The environment indeed does affect all the interventions taking place in terms of a room that have the patient's children in it. How do you actually get the patient into a different room, and how does it affect them when exposure-based treatment takes place, when they're at home right after, and so forth. The use of interpreters have been another challenge when it comes to using digital formats, also due to technical difficulties. And also, and this is important, I think, and I think again, this is Sarah highlighting this difficulty, that we risk normalizing distance assessment, for example, when it comes to other external actors that might require that we do deliver assessments, interventions, and so forth in this digital format, and this might actually create a deterioration when it comes to quality if we do this too well, so to speak. We need to evaluate this over time because, as Koji pointed out, it is also a possibility. All of a sudden, we are able to and have all the formats required in order to deliver treatment from afar. We can reach parts of Sweden where we have no treatment centers, and we can reach patients whose health is so poor that they can't get here for psychological or physiological reasons. So it's an opening, but it's also something that we have to consider the results and the normalizing aspect as well. This, I think, the fourth and final track has been utterly important, and this is perhaps over time at least the one that I like to consider the main track, communicating the vulnerability of our patients. In this crisis too, our patient group is one of those that have been hit the hardest. And we've been trying to highlight this in dialogue, the internal dialogue within the Swedish Red Cross, but also with state, with the region, with city council, and other partners and institutions that we cooperate with on a daily, weekly, yearly basis, that it has to be remembered that, again, our group has been hit harder and has to be considered on special terms. The UN published a PM, I think it's called, I don't know, with the title, The Need for Action on Mental Health, Considering COVID-19, and highlighted those things that we also see and who has a strong impact on mental health. The isolation that our migrant group or our patient group experiences, the fear, the family's vulnerability, where we also see that children and women are at risk when families are isolated due to health restrictions. Development in the children, but also when it comes to integration issues. The sense or the feeling of being left behind, being outside a society that all of a sudden, so to speak, seals itself, and you're not even part of it. The information doesn't reach you. And a lot of our patients have depicted the situation at hand as what happens before the war. So it's familiar to them and therefore also risks re-traumatizing them. So apart from the impact on mental health, there's also the impact the UN states on mental health services that in many countries, in countries of origin, but also in countries that they reach, such as Sweden in our example, are often restricted. There's no access to mental health services, and the COVID-19 further restricts those. So what we see, this is a picture that I stole from a colleague, I think. What we see in our patient population is that apart from the trauma, they carry a heavy load. Many of them carry a heavy load from before and will keep doing it in their goal country. And the COVID-19, I think, is another burden and tends to aggravate all of those, the poverty, the neglect, the financial insecurity, and the RCCE also made a publication, and this has served as a guidance for me and our team when it comes to highlighting the fourth track. Keep considering in terms of when we design our strategies, when we design our treatment interventions, how to try to include our patients when it comes to the access to information, access to healthcare. You can read this yourself, I think. how they're affected by reduced mobility or actually by a mobility, at always being on the run or being moved from here to there within your new country, for example, that this will affect your response to COVID-19 as well. The financial vulnerability, again, is a part of our group's dilemmas. Many of them belong to risk groups due to physiological factors or other parallel conditions. Their living conditions are often cramped, which means that they're also more exposed to the risk of being contaminated by COVID-19 in a family setting, for example. And also, which we have experienced and which some of them also will tell us about, the racism in healthcare in terms of lack of information, lack of considering lack of information, and also that your symptoms, above all, will be interpreted differently when you actually seek healthcare. So this I do recommend. It's a publication that has been taken forward by the Red Cross and the Red Crescent Societies, along with, among others, the UN. I think that's the end of my presentation. Thank you very much.